Hi everyone, welcome to the first episode of Foundation for Cancer Care's Cancer Conversations, where we'll be discussing cancer care, cancer prevention, cancer survivorship, and everything healthcare was in relation to cancer care. And we'll be starting today with our first episode on healthcare leadership. Two amazing leaders in healthcare with experiences to share and a journey to share. So if this is something that interests you in any way, make sure that you listen to the end. Come with us. The conversation today will be focused on women in leadership in cancer prevention. And with me today, I have Dr. Oge. Dr. Oge, would you like to introduce yourself?
Hello, everyone. My name is Dr. Oge Ilebune, and I'm a family physician. I'm also on the board for the Foundation for Cancer Care as an advisory person. I'm also the medical director for Lakeshore Cancer Center. It's such a pleasure to be here.
It's good to have you here,
Dr.
Dr.
Tolu
Oge.
Animi.
Thank you for joining us. To my right, I have with me the amazing Nurse Cynthia. Nurse Cynthia, do you want to do a quick introduction?
Yes, thank you. Thank you for having me here. My name is Mrs. Cynthia Ikejani Niwogu. I am a registered nurse, have been practicing for so many years, and I am the nursing administrator here at Lakeshore Cancer Center.
Oh, wow. Okay. And I'm your amiable host for today, and I'm Dr. Toluwanimi Ajuloju. Just in case you are wondering why we're having this conversation on women's leadership in healthcare, I would like to highlight that cancer is one of the leading causes of mortality in Nigeria and globally. And women play a crucial role in cancer prevention, advocacy, and policy making. We have seen women who have done so much in healthcare, and we have decided to bring those that are close to home, where we can see them, hear from them, see the contributions that they have made, the challenges they have faced, because generally, women in leadership actually do face challenges, and women in healthcare face specific challenges. And while we are highlighting the challenges, we are also highlighting their triumphs, the things that they have done, and we are open to see more ways in which we can support them collectively and as individuals. All right, so Dr. Oge, how long have you been in the medical space?
Oh, wow. I can't even do the calculation, but I graduated in 1998. Actually, officially, class of 1996, but we had two major strikes at the time. That's a story for another day. We have been striking for a long time. And so if you do the calculation, that sort of tells you how long in total. But in terms of my time within the cancer space, the oncology space, you can date that to when I first moved back to Nigeria in 2014 and then joined Lakeshore Cancer Center in March 2015.
Oh, wow.
So it's about 10 years. About 10 years.
Yes.
About 10 years.
Well done. So how has it been? How has the journey been in 10 years? Basically, I would like you to highlight how you have moved from different. You didn't just come in and become the MD at Lakeshore Cancer Center. So you definitely moved from different roles to another. So let's talk about that.
Yes.
How did that transition go?
Right. Thank you. So I never envisioned this, when you have people like say, oh, what's your 5-year career goal? What's your 10-year? This space wasn't featured in that.
Your 10-year goal.
No, it wasn't, because I was in the UK, I was working as a family physician, and I was purely clinical, patient facing. That was it. And I loved it. Until we sort of thought, the family, we wanted to come home, people always say, yo, you've come to impact, but actually, I think it goes both ways. The country impacts on you as well. Yes. And we wanted to do that. And so I came to Nigeria. At the time, everyone thought it was brave because I actually didn't have a job.
Oh, wow. So you came all the way from the UK without a plan,
without a job,
and, to Nigeria.
Which was very unusual because I would normally have a plan. But I think because this was a situation, I'd been out of the country for about 14 years. I didn't know what the landscape was. And my husband said, oh, by the way, it's Lagos. It's no more Abuja. And all the stories about Lagos, traffic, hustle. I just said, you know what, I'm going to breathe out a bit, come in, settle the children, and then sort of, see what was on the ground. And that was what I did. Just intentionally and actively started attending conferences. I've always loved networking. And so I thought that's where to meet people and hear what is on the ground, whether it's the public sector, private sector. But I already sort of had an inkling. I didn't really want to, do the core public sector teaching hospital. I was open to ideas. And then I met Dr. Chumi. And someone said to me, oh, there's this consultant, he's opened a facility, it's 8 months old, and they're looking for a family physician actually, and that link was made, and we got talking. And he said, oh, yes, we do need a family physician. But by the way, we also need someone to drive the cancer prevention and screening arm. And I'm thinking, oh, okay, so you're going to get me as a family physician and then you're going to employ someone else. And he's like, no, you
do both.
you are going to do both. And, if you know what the system is abroad, at least my own experience is things are already set up and you graduate and you get onto the conveyor belt. So I went from, doing my hospital rotation to getting the GP registrar role, then in the GP practice. So, there was some sort of order. The cancer screening was already there. Once you move into an area in the UK, you're registered in a family practice. And automatically, because they have a national cancer screening strategy, your name, the algorithms comes up, okay, female, 25 years old, you already have your cervical cancer screening letter coming through. We didn't have that here. And that was what Dr. Chumi actually wanted us to try and do at Lakeshore. Have some sort of internal recall, education and awareness. And so that began my journey in that space. So I was still seeing patients, cancer patients with comorbid conditions, hypertension, but there was now a mandate that we also needed to take the information out there to people. And I had to figure out with the rest of the team how Lakeshore was going to do that. And one of those, funny days, we were now thinking, okay, so what's your job title actually? And we tried different, is it this, is it that? And then I think it was Bindia who said, oh, how about head of strategy, outreach and business development.
Oh, wow. So something like that. That's how that name came up.
It was a mouthful because, the board figured I would help with the outreach, which was the community engagement. I would still help with strategy and business development. And suddenly, this doctor who had no MBA, no financial literacy, I'm really bad with finance. I'm suddenly, in that role, attending board meetings, talking about budget.
So would you say you literally had to learn on the job?
I learned on the job. Yes, I learned on the job. So that's my role up to that point. And so to support that role though, and that's where, Lakeshore is, we're talking about women and gender equity, equality. The board led by Dr. Chumi and the chairman of the board, Paul Wanwanibe, they're very keen that this Lakeshore space gives equal opportunities to women. And so it was a case of what do you lack? Where's the gap? And that's where I went for some programs to boost that learning, to consolidate it. So I did a few things, the healthcare management program at the EDC under the Pan-Atlantic University and Lagos Business School. I did a healthcare finance because
so basically the organization sort of intentionally invested in your growth to make you more suitable for that role.
Exactly. So that's how the journey started.
Okay, so how did you end up being the medical director? Because now we know from when you started family physician, transition to this head of strategy and business development, and now you are the medical director at Lakeshore.
Yeah, so it's an interesting journey because, I think Nurse Cynthia would also, add to that when she speaks. As Lakeshore has evolved, so many things have evolved with its roles. The organogram we started off with at the beginning is not the current organogram. When the organogram changed and we started evolving, it also meant that job descriptions changed, roles changed, they were additional. And at some point, the board felt that, okay, we've gone past having a practice manager type of, we now need a medical director role. And it was a question of how do we get to that role? And so in January 2024, right? This is, the board of Lakeshore offered me the role of the medical director. We had a conversation and I started the job. So it's a steep learning curve. You think you know some things, but you don't know it all.
How has it been?
Yes, it's been interesting.
Because you literally carry the burden of the whole organization on your shoulder.
That's what it might seem like, but actually it's not what it appears to be. Or is it the other way around? Because the teamwork ethos we have here, the strong management structure we have here, almost seems like I'm just overseeing, because we are working together. We have a strong board, we have a strong management structure, and the staff are wonderful. So even though it might seem, you uneasy lies the head and the crown.
Where's the crown?
Where's the crown? But, I must say, having colleagues, having the sort of vision and mission within this space makes it a light burden. But about 3 years ago as well, the Foundation for Cancer Care, which had been dormant, the Foundation for Cancer Care actually gave birth to the clinic. And when the clinic started, the foundation sort of calmed down while the clinic grew. But about 3 years ago, the board of Lakeshore thought we needed to resurrect the foundation because already Lakeshore under the outreach, we were doing so much. But it was also so pertinent to remember that we are still for profit. And funders also found that a bit difficult. You know, you want to give a fund, but it's a profit. So how does it work? And so the Foundation for Cancer Care was resurrected under the, a new board, new staff, new leadership, that's the word. And so I was then invited to be advisory on the board. So I'm not a board member per se. I'm advisory on the board, and particularly my area of interest or emphasis in the board is patient selection for the different activities, exactly, and giving support to the leadership of the Foundation for Cancer Care.
Thank you very much, Dr. Oge. It's so good to hear and actually see you in that journey. I mean, I met you while you were in the role as the head of strategy, and I'm seeing you in the role as the medical director, and I can say that you are doing an amazing job so far.
Thank you.
And well, we'll still have a long conversation.
Sure.
I'm sure that by now, Mrs. Cynthia actually wonders if I plan to say anything to her.
Well, I know, but I'm enjoying, the whole conversation, everything going on with Dr. Oge. Congratulations, you've done a lot, Thank you.
Cynthia.
Not Cynthia?
Yes.
So, like I always call you, not Cynthia, not Cynthia. So, I just want to know what exactly made you venture into oncology space, because I think that nothing is very broad.
Yes.
And you can as well do a lot of other things. But why oncology?
It's a long journey, like you said, I am a nurse. I graduated from the Florida. I was in Florida. I was in US. That's why I went to nursing school. And moving from Florida to Canada, working as a nurse has given me so much experience, so much exposure, that when I finally got here in Nigeria, I had a friend who, unbeknown to me, was battling cancer, but didn't really open up. But she was in US, took all her treatments in US, and then because she wanted to be around family, she wanted to come back home. And it's not because she couldn't afford it in US, but she wanted that home support. So she moved back to Nigeria. She was given a reference to come back to Lakeshore.
Okay.
And that's how she came here. And while at Lakeshore Cancer Center, she's like, oh, wow, there's a place like this. This is wonderful. It's like I'm still in US. The treatment she got, the service was wonderful, was excellent. So as we were talking, she just opened up and she started telling me a lot. And knowing that I've been back for 2 years and I wasn't working as a nurse, I really needed a break from nursing.
Can be very
yes, you can burn out very easy. And I think with me working in US, Canada, I was a bit burnt down. So I really needed that break. But as we were talking, she said, Cynthia, because I know you love patients, you love your patients, the way you talk about nursing, I think you'll be a good fit in this hospital that I went to.
Okay.
I'm like, how do you know? I don't really want to work here in Nigeria. She says, try it. Honestly, I came, saw, and stayed.
You were conquered.
Okay, so that was the old journey. So.
Yes, so it gave me that, there's a buspa, like the Jewish people say it. It's like, I know that I belong here. I see that my patients love me, need me, and I love them. It was a two-way thing, So cancer care or oncology care, it's not like giving birth. It's so different. It's not like having malaria, you give in 3 days of injection and you go home. It's a long process. So once you get attached to the patients, once you start the patient care, they trust you. And they tend to have a lot of time one-on-one with nurses. And they open up to nurses. With doctors, it's 10, 15 minutes and that's it. They spend hours with us. So by the time we're talking about their children, their life, so that their mind is not always on the treatment. Yeah. So they open up and we open up. There are things that, it becomes a conversation. So that's how I got to know that I am really in oncology, and that it's a calling for me.
Great. So it's good to know that, because there's one thing that you both have in common actually. You've done life abroad and then you came back to Nigeria. So it feels like you transitioned from two different spaces.
It's called Jakbada.
So again, I'm excited that we have things that we can all share in common.
Yes.
And that would also mean that maybe, just maybe, you might have common challenges too in leadership. So I would like to ask Cynthia. Now, Cynthia, in your role as a nurse, currently, I know that you are the nursing administrator at Lakeshore, and you didn't just start off as a nursing administrator.
No.
So it would be nice to actually have an idea of the kind of challenges you have faced as you transitioned into different roles to this point, and how you have navigated them.
You know, since I came back, I used to work only 2 days a week or 3, and it's continued like that. I used to go back to Canada, practice, do my thing. But then when I was just a nurse, an oncology nurse. And when I was now given the position as a nursing administrator, I'm like, wow, I used to be a head nurse in Canada for many, many years. I was director for nursing. So I knew it was something that I could handle here. But it's different when you're director for nursing abroad, because everything is provided for you. It's easy. There's lights, there's road. But here, with family, with everything, it was a tough decision. But, but because of the love and the empathy and Lakeshore, I don't know how to say it, Lakeshore cares. And that's our logo. And it was easy for me to accept that position because it's something that I know while I'm there practicing, I'm also teaching. I'm also extending, because you can't give what you don't have.
True.
Yeah, you can't. So since I know that I love this oncology, and I am there to help them fight through, whether it's palliative, whether it's hospice, end of life, whatever it is. Cancer is not a death sentence.
Yeah.
And because I know that cancer is not a death sentence, it gives me that strength to continue teaching both the younger nurses, teaching the patients, and everybody around me. Even in churches, I'm always preaching, screening, cancer care, but it's not an easy battle. It's not an easy battle. And so I don't know if I've answered all your questions.
So I would actually like to hear your perspective, particularly to leadership as a nursing administrator. For context sake,
yes,
you know that there will be times where maybe you need to get some things done. Maybe you don't have enough hands.
Yes.
Maybe you have a lot of patients. There will be days when you have to see multiple patients receiving multiple chemotherapies, and they need a different side of Cynthia.
Yes.
So there's the patient that needs the Cynthia that wants to cry but Cynthia has to administer chemotherapy.
Yeah.
I mean, she has many other things that she needs
You wear
to do.
many hats.
So exactly. So how do you do that and still show? Because I don't think there's been a time that I've ever seen you without a smile. And even if there is a time where you're not smiling, it's just very short-lived. So it's like you have to be multiple things at the same time. And like Dr. Oge had said, being in that space generally, you have to be able to be many things to many people.
Yes.
So how do you juggle all of those things without dropping the bar?
I think it's by the special grace of God.
I was really hoping you were not going to say that.
I am, honestly. That's how the strength, the family support,
family support.
Yeah, my own family support goes a long way. Like I said, you can't give what it's hard. I must give what I have. And what I have, I know, is the love, the empathy. So it's easy for me. And as a nurse, and I teach it to the younger nurses, you have to be patient. You have to have that endurance. You have to have that strength, to be able to juggle along all these things that come your way. So as a leader, it's not easy, but I have to show by example. I have to be there. And the patients, if I'm not taking care of the patients, there's no way I can assign a nurse to do that. So I am doing it. They can see that I am doing it, and I expect them to do it.
So basically, you would say that when it comes to leadership, particularly in healthcare,
yes.
your would I say your own template is to lead by example yourself?
I lead by example, and I know that one thing I always believe in is listening to your patients. It's very easy. Once you listen to your patients, it's easy to respond to their needs. If you don't listen to that patient, there's absolutely no way you can respond. That's when you get frustrated too. So you won't be able to deliver the care. And so because of that, as a leader, you lead by example, you show, you nurture your nurses into leadership. You can't be alone.
Nurture your nurses
into leadership. Yes. So for that, and I always say, I'd rather have 2 nurses dedicated, full of empathy, love, cares for the patient, than 10 nurses who don't care. You know, the 2 nurses can take care of my chemo lounge and patient go home satisfied. Then I have 10 nurses, everybody's running up and down and don't know what they're doing. So I believe in dedication, and anything you're doing, research is very important. I'm going to take care of a patient with cancer, breast cancer. I will research a bit about breast cancer. Everything is not textbook. It's what the patient is telling me. It's the signs and symptoms she's coming with is different from signs and symptoms the other person is coming. So you can't treat them the same way. But one thing I know that is common among all of them is communication. Listening to them goes a long way. So this is what I would always pass on to my nurses as a leader, and I hope that every one of them also grow up into leadership. You know, and that's what we're doing here at Lakeshore. When we even employ new nurses, we bring them in and say 2 weeks, just make sure this is really what you want. Because you can say, oh, I need a job, and you come in because you need a job, and 1 week is like, what?
You are done.
Is that what it is? No, yes. So you really bring them in and you coach them, you talk to them, you inspire them, you let them open up, because sometimes they're like, I've never seen a Porter card. I don't even know. I always say, oh, I give chemo. And then they come in and like, wow, this is different. Oh, look at all these pre-meds that they are given, how it's being given, how you explain, I'm carrying this chemo and I'm showing the patient, this is your name, this is your weight today, this is your vitals. So you carry the patient along. So once you do that, and the patient is like, oh, thank you so much. That hand that she's holding there means a lot to her. And for me as a leader, I come in, I peep, that's what I want to see. Thank you.
Thank you, Cynthia. That was a really intense one. So from this particular conversation, particularly with Cynthia's journey, I think what I already take from this is the amount of intentionality that goes into patient care, particularly when it comes to cancer care. And basically this conversation has been focused more on those that are already in treatment.
Yes.
And I would like us to take a little step backward and redirect ourselves to those that are apparently healthy and we are trying to prevent from having cancer. So now I'm going to be speaking to Dr. Oge. Dr. Oge, you are the board advisory at the
We didn't forget you, Dr. Oge.
So you are the board advisory at the Foundation for Cancer Care, and the Foundation for Cancer Care literally does a lot of things for indigent people in community. And the focus is mostly cancer prevention, cancer screening, and education and awareness. And I just want to hear your perspective on how much you think prevention has improved cancer care or will improve cancer care, if you think it hasn't improved so much. So I want to know your thoughts. First, has cancer care improved in Nigeria, and how prevention has improved cancer care in Nigeria?
Okay, thank you very much for that. I was already swimming, listening to Nurse Cynthia. It's just amazing. And so, to answer your question, I'll sort of take a little step back.
Okay.
When I was in the UK, I didn't consciously think about cancer prevention.
Oh, wow.
And I'll tell you why. Because the infrastructure was in place. I didn't have to do anything. All I needed to do was look at the prompt on my laptop when I saw a patient, which told me or reminded me, ask about smoking, ask about alcohol, ask about pap smear, ask about mammogram, ask about this, that,
there
that.
There were systems in place.
There were systems in place. I didn't have to consciously. All I needed to know was, as a good doctor, I needed to tick off all these prompts. And like I mentioned earlier, once you move into an area, one of the first things you do is you register with the GP practice, and that registration signals across the system to say this family is registered, they have children under 5. So all the under 5 checks, they have a woman who will need her pap smear, who will need her mammogram at some point. Oh, and there's a man there who's, all that, and your letters are arriving. It's up to you whether, when my letter arrives, whether I go and book my appointment. And so that is the environment I came from. And then fast forward, and I come into Nigeria,
where you usually have to cajole people to even show up.
It was a question of, okay, Lakeshore, what are we doing around prevention? And all the stories I was hearing, people were not having their pap smear. This wasn't happening, that wasn't happening. And Lakeshore said, we're not going to sit at the clinic waiting for patients to come in advanced cancer, stage 4s and all that. We are going to take it out there. And that opened my eyes a lot. So one of the first things we did was, what are the guidelines for cancer prevention? Anyway, that meant I then went back to school effectively. Because remember, before, or prior,
There were
it was
prompts.
there. There
Yeah.
were prompts. I didn't have to overthink
Yeah.
anything. So I had to go back to school to say, what are the different guidelines? That's when I realized the guidelines for the US was different from the UK,
Yes.
was different from other areas.
Yeah.
But there were some common threads, okay? So what was our guideline going to be at Lakeshore? And so we had to pull it. And our guidelines are the same guidelines we've been using, but just tweaked as
And
we
then it
go
keeps
along.
evolving.
Because when we started, colorectal cancer screening was at 50 years.
Yes.
Now it's
Gone
at
to
45,
45.
and in Nigeria it's at 40. And so the role meant that I needed to keep up with the trends and educate the clinic as to what was going on. And I think in the 10 years, what has changed is that narrative, the voices have increased. So I'm not here to say that Lakeshore is the only place where all this was happening. I think as we also had even more people coming back to Nigeria, it was amplifying that voice and that narrative. And then step in the Nigerian Cancer Society, which then became the umbrella under which all these other like-minded facilities, whether it was Lakeshore, whether it was Project Pink Blue, whether it was our foundation for cancer care when we became active, started coming in. And so we were learning from each other, and it was evolving. It wasn't smooth, and we needed the government buy-in as well. And that's where the policies you're talking about comes in. And so I can say right now that preventive care has become a thing in Nigeria. I don't have the statistics or the percentage, but when somebody calls me to say, Dr. Oge, where can I go for my screening? So I belong to various women's group, whether it's my secondary school group, whether it's my church group, CW, Catholic Women's Organization, whether it's even my own medical school group, and people are asking questions. Those questions are coming a bit more than before. Before, I was the one posting on these groups because Lakeshore, we already, even before it became the thing to do, we would make a little flyer and we'll be posting it. My classmates always said, at some point, you don't even have anything to say in this group. You're just posting cancer, cancer, cancer. And people would shy away. Like they didn't want to hear it. But I would say in the last 7 years, 5 years, people actually say, oh, listen, I want to come for my screening. Where can I go? Do you do this? People, the narrative is changing. And because the narrative is changing, as much as the government might sort of not put enough money in healthcare, not even just cancer care, healthcare, they are beginning to hear the voices. And so I think 2 years ago or so, the government then instituted NICRAT, which is this is the government's own agency, separate from the Nigerian Cancer Society, that is now looking at cancer research, prevention, working with NICRAT and Nigerian Cancer Society, then working with HFN. Suddenly, the conversation is being had so much that at least about 2 years ago, Nigeria decided to take that step and accept vaccine from Gavi. And we started talking about vaccination, HPV vaccination, which is a preventive thing. Before that, Lakeshore was doing that. So we've always run with doing it our own way. All it meant was we would sit down, do the research, do the conversation, our clinical meeting, and then of course the foundation stepped in because Lakeshore was already doing all that community outreach education. But once the foundation took the mantle and the mandate, it became a different game. It was a game changer.
So I would like you to actually highlight the journey of the foundation, particularly with the preventive part of cancer care. I know that the foundation does a lot of education and awareness, but the community screening that the foundation does, I would like you to highlight how much of influence do you think it has in the actual sense of it?
Yes. So, when I think back to the list we had, so the business development team for a very long time held the outreach activities for Lakeshore. And we had a spreadsheet where we would put all the activities we were doing. And sometimes we'll come to the meeting and look at that activity list. And I would say, oh, wow, we really are making progress. But like I said, the foundation became the game changer because it became easier for organizations to want to fund a non-for-profit. All right. So we had AMPA, Association of Nigerian Physicians, in the Americas. We had companies, indigenous companies in Nigeria. We had, individuals wanting to bring money. We had a family who lost a sister, not at Lakeshore, but they heard about the foundation and the brought funds that actually covered a lot of screening over years. And so when we look at the impact report for the foundation, it sort of tells us, wow, even though it seems like we're just still scratching the surface, there is
a
a
lot
lot
has
of
been
work, a
done.
lot has been done.
Mm.
And what the foundation does is it's not just focused on the treatment, because we fund treatment for radiotherapy specifically. But what the foundation has done is to decide what are our target populations here. And they have gone out into the communities. They are listening as well to communities, and they don't restrict themselves. So we've gone to mosques, we've gone to churches, we've gone to markets, we've gone to schools. You know, in fact, we have now a particular school that has us on their, their rota for every year coming in to educate. But the other thing the foundation is doing is catching them young, because, for instance, I taught my daughter how to do her self-breast examination. I taught her that at a certain age, you're going to start having your cervical screening, but before then, let's do your vaccination. And the day my daughter told me, oh, mom, at school, I'm teaching my friends how to do self-breast examination, I knew, okay.
We have made a win is a
win. Exactly. So on a broader scale, the foundation is going into schools. They call it the Crush Cancer Early program. And they are going to schools to talk to young people, not in an alarming way, but in a way that the children can relate. And so these children are the ones who are going to tell their parents, oh, mom, dad, I need to get my vaccination done. I need to do this. I need to do that. And I would thank the school authorities that actually allow the foundation to come into that space, because just to remind us that this is still Nigeria, this is Africa.
And
the
it's
stigma,
tough.
the bias, the fear.
A lot of them still don't believe that the vaccination is actually for cervical cancer.
That's a story for another day.
Yes.
Because we know what happened when the government now instituted the national program for vaccination and all that came up with that. But, so that's what the foundation has been doing. And I think that whole idea of education and awareness is something we do so well.
Yes.
And the other thing that works well is the collaboration.
Yes.
I've mentioned the Nigerian Cancer Society, the NICRAD, but what we've done is we recognize that we can do it all. And so, for instance, even though we do not fund chemotherapy or that, we have other organizations that fund all that. So when a patient comes to us, we don't say, oh, right, we're only funding radiotherapy, so we can't help you. No, the foundation says, oh, we only fund radiotherapy, but we have other partner organizations that we can put you through to, Medicaid, Project, that's the beauty of it. There's no competition in this space, because the Nigerian patient is worth it, the cancer patient is worth it.
And I'm hearing that most HMOs now are agreeing to the screening before, to the screening part, which is what
that's very important.
Yes.
Years ago, the HMOs did not fund anything. There was no point talking to the HMOs. It came from, so there was a bank. We used to go and do examinations, breast examination. They had a clinic at that bank. So twice a year, the medical director for the bank would say, Dr. Oge, it's time. And so the nurses and I would go and do the prevention, the discussion. And that was because the bank, the HMO had no relationship with all this. But fast forward, the bank called us and said, we're not handing over to our HMO. So every year for our annual screening, you have to go to the HMO. And that was brilliant, because it meant more people were also getting screened.
I absolutely love the example that you gave, because this particularly highlights the importance of having somebody in the leadership space that has an idea and sees the importance. Because imagine that person that said, oh, we need to do a cancer screening for our women in this organization. Let's assume that the person was not there. And somehow we underestimate the influence of women in getting other women to access care. Because if you check out things, people have had to fight, not physically now, but if physical, but people have had to fight for the kind of wins that we have in healthcare right now. And if we are going to focus on cancer care, people have had to fight to say, even in the space of policy, when you are making that budget and you say 15% is supposed to go for the whole of healthcare, how much then do you allocate to cancer care? Because we all know that one of the major challenges and barriers to cancer care that we have is financial constraints. An average patient that comes in rich literally lives poor. Bankrupt. In fact, that's the right word.
Selling their properties.
I had a call yesterday of a patient who said in their journey, they've literally sold everything. I said, Dr. Oge, I don't have anything. I live at the, at the mercy of. And then I also had, about a month ago, another patient who came to us, and someone said, listen, this patient is very ill. I'm sending him to you. I'm going to pay all the bills from now until the diagnosis. Because what people don't realize is there's a lot of focus on the treatment aspect.
Yes.
But there is money needed for you to get a good diagnosis, whether it's your scans, whether it's the consultation, whether it's the blood test and all that.
Chemistry.
Yeah. So this person said, I want a diagnosis for this. I think there's something wrong going on. So I'm going to fund that. We will cross that bridge when the diagnosis has come, but let's get a diagnosis. And so many people are at the mercy of other people's kindness and generosity. And so when the HMOs, like you said, is now funding not just the treatment, but they're also looking at prevention. And we know that early detection
is the key.
It's key. It's key, yeah.
I just wanted to mention, when you were talking about the leadership, something I was reading about that in healthcare globally, you actually have women constituting about 70% of the global healthcare workforce.
Yeah.
And in universities and colleges, you have over almost 59 to 60% of women in, whether it's the medical sciences, nursing and all that. But when it then comes to executive leadership roles, it's less than 25%.
Yeah.
And so the question is, what happened from that 70 down to that 25?
Yes, and I think that I would like us to actually break that down, because we underestimate the power of women to drive change. If you go to every home, there's a woman there. And for every woman, there are children or relatives that they look after. And I think there's this nurturing thing that is just, I would say maybe God puts it in women, that comes with them. So an average man or woman that is getting some things done, an average man or child that is getting some things done, is getting it done because there's a push behind, and most times it's always a woman. So if I got to the school, got to this level, and then you just relegate me to the backside, oh, you can do everything but not the leadership, then at what point do you want me to make significant impact? So I think that I would like to actually see or hear your thoughts on how important it is to have women. Actually, I want to hear from both sides. How important you think women, or the important roles that you think women play in driving the force of healthcare and cancer prevention.
So I love history, and so I always go back, okay, whether it's recent history or past history. And I was told by my mom that her aunts, whom she was sent to live with in the village, because my grandparents were very urban, Zaria, Lagos, and they felt, these are my children.
Let's
send them. So they sent my mom and her younger brother back to the village to live with this aunt. This aunt had been married and got divorced as far back as then. My mom is in her 80s. And so she came back to her father's home and became a leader, a woman leader. And I said to my mom, I didn't know there were women leaders then. And my mom said, society respected women then. That as much as we know that there are some traditions that were detrimental to women, but there were also societies that women were, you had the Umuada, so I'm Igbo. So that powerful group of women. And that this aunt was so rich, she had her business. The men in the village came to borrow money from her. They came to borrow money from her. But more importantly, she mentored young women.
Yes.
She was also a depiction, a role model of a strong woman and a woman leader. And my mom said she was very lucky and privileged to be under her roof, to be mentored and groomed to be a woman leader. And then generationally, you pass that on. And so coming back to your question, I think in the evolution of life and society, somehow women have managed to then be relegated to the back. And we know that 1/3 of patients always want a female physician. 1/3 of patients would want a female surgeon. Okay. And so society and the healthcare space, actually, we need to listen and be driven by these statistics. Because if a woman comes, and we know as well, like in the Middle East or even within Nigeria, where you have religions where the women cannot even see a man. Can you think of how many women are actually not accessing care or having that need to go to a hospital because they feel that it's a man that they would see there. So I think it's very important when we support women, and I'm saying we, not just as women supporting, but whether it's government initiatives, that there's a role women have in drawing care
I agree
or
with
giving
you.
care to patients
Yes.
and female patients as well.
Wow.
And I also wanted to sort of mention that in as much as, yes, women are nurturing, I don't think that's the only thing about that gives women that leadership or the ability to draw patients. I think in addition to nurturing, women are fantastic multitaskers.
I absolutely agree with you.
Women have the ability to multitask with all due respect to the men.
All respect to the men.
At a level that men
cannot.
are not able to. And we are equipped differently.
Yes.
The men bring something to the table. More than they bring something to the table. That multitasking ability and being able to see beyond what's on the surface. Sometimes I watch Cynthia and we're at clinical meetings or meetings and she's quiet and she's listening and we're all talking. Then suddenly she says something. And that's leadership, female leadership thing. She's looking foresight. She's looking beyond just what we're discussing. She's already thinking beyond, okay, but this is what might happen. So I think the women's role in prevention as a leader means that we have to think beyond just the moment. We have to look behind and we need to look ahead and also think, if you're not preventing, then what numbers are we looking at? 2030. We all know about the 2030 mandate.
Yes.
90, 70, 90.
90.
How is that going to happen
when we are not preventing?
If we're not preventing? And you need women.
That's a very big question, actually. I mean, if we evaluate how far we have done now, and 2030 is just
around the corner.
Around the way. Are we really heading towards 2030 mandate? Well, that's a good question to ask.
Yes.
Just to pick up what you're saying about the role of women in leadership.
Yeah.
Very, very important. I'm just going to say one or two things, just like she's, talked about her aunt, how, she became what she is and her mom saw it. While I was in Canada too, I was the woman leader for 15 years for the Igbo Association for 15 years. And it's supposed to be for 5 years. But every 5 years I wanted to step down. But I was there till I think 2015 2016 till when I came back to Nigeria. I had to there's no choice. The reason why I'm saying this is that maybe that's where the leadership honestly has a lot to do with listening. Communication, listening.
I can already count how many times you mentioned listening in this conversation.
It's very important. I'm with Dr. Jimo most of the times and I listen to him. I go with Dr. Iwuji, I listen to her. I go with Dr. Chidi. They're all our consultants. And with my patients, with Dr. Oge, I listen. But one thing is that after listening, I wouldn't want anyone to step down on my opinion. Let people say their opinion, and it might not even be correct. It might not be what is needed, but allow people to say it, to speak.
All right. Thank you so much, Cynthia.
Thank you.
So just in a bit to wrap up this conversation, I would like you to highlight an advice that you would give a younger nurse looking to do something in healthcare and most likely looking to grow into the leadership side of healthcare. And I would just like to hear what advice you would give a younger nurse in that perspective.
I always tell younger nurses or people who want to be a nurse, make sure you want to be a nurse because you have a lot of love, empathy, you have something to give. Some people, everybody's rushing to do nursing because you can jackpot. And no, it doesn't work like that. So my advice is make sure that it's a calling. It's something that you love. You love people. You're open to communication. You're open to listening to people. Have patience, If you don't have those qualities and really think you're just going there to make the money, you will not succeed.
So even as a leader in the nursing space, if you're looking to evolve into an healthcare leader, basically for a nurse, the advice you would still emphasize is that you make sure that you are empathetic.
Yes.
You're actively listening to people.
Very important.
And you really care to be in the job.
Yes. And you're not just a nurse. It's a nurse with an impact.
A nurse with an impact. So you're not just a nurse, you're a nurse with an impact.
Yes. You want to make, a lot of impact. Go for training, we learn on the job, just like Dr. Oge said before. The things you learn in the textbook, in the school, once you're on ground, it's totally a different ball game.
I don't even think that the nursing curriculum actually specifically caters to leadership in nursing
and a lot of things. So it's like when you are on, when you're working, when you're with patients, when you take care of patient A, your experience with patient A would help you with patient B. It might not be the same, but you're going to see what works for you, and what works for me might not be what works for the other person, but I believe that listening to your patient is the key, making sure that you're understanding what the patient is telling you. The patient that comes to you, I tell the nurses, and you're asking the patient, are you in pain? Are you in pain? And they're not answering you, but they're like grimacing. Look at the face. Assess your patient. You must be able to assess your patient. And, turn the words. Is it hurting you? Where is hurting you? Find out where. Don't assume. Let them show you. Let them communicate with you. It's very, very important.
All right. So thank you so much, Nurse Cynthia. And yeah, when it comes to leadership in nursing, as you transcend the roles, you must be able to intentionally evolve, learn more, and see how best you can adopt your experiences from different patients into the roles that you transition into.
And also go for training, a lot of there's a lot of things online. You have to advance, you have to enhance, you have to do a lot of things to learn, because every time things are changing. You have to know what works. Yes. So we have ONS, which is Oncology Nursing Society, that we are also associating with. That means that they will give you training too, that will better your knowledge with oncology. So Lakeshore always provide us with a lot of training, and we go for, we follow research, so you can't do anything without research these days. So a lot of times I tell people, do those things and better yourself. As you're bettering yourself, that helps you to climb up into leadership.
All right. Yes. All right. Thank you. Thank you very much, Cynthia. I just want to add this to the question, because it is one thing for you to actually climb up through leadership. It is one thing to remain in leadership.
Yes.
And it is another thing for people that you lead to actually acknowledge and appreciate your leadership. So do you think that when it comes to leadership, there is a different scenario to it? Because, for example, when you are leading different people with different emotions, with different reactions. We are not all on the same level, especially intellectually. So how do you think young nurses, as they evolve or transition into roles, how do you think they can also do this while carrying along those that they are trying to lead?
I still believe it's in communication. I still believe, because you can lead if you're not communicating with that person. When we go for training, when we go for outreach, when we go for whatever it is, they're telling you something. Are you understanding what they're telling you? And are you asking questions? Because once you ask questions, you'll be able to get an answer. A lot of people, they come in, even some patients, they have problems, they're not helped, or they were not given the service that they think they should have been given or gotten, and they keep it to themselves, and they're suffering. But once they sit with you as a nurse or as a leader in nursing space, they might be able to open up. From asking them, one question leads to another door opening, and they'll open up and they'll say, okay, let me tell you this now. And by the time you know it, they will say, oh, this person didn't treat me the way you're treating me. I wasn't, nobody was listening to me. I was telling them that I had a headache all night, and then nobody did anything about that. So by the time you start talking to them, they will open up. It's now your responsibility as the nurse to assess their blood pressure, assess if they slept. If anything that you can get from that patient, you must communicate that to the doctor. It could be that they are hypertensive and they don't know. And in Lakeshore, we don't treat only cancer. We treat holistically. So once you have one problem, let's say people come in and they start fighting just to treat that cancer, and they will forget their blood pressure problem, or they just say, no, let this stay by the side, forget they're diabetic. But you know what? At the end, we can't even further that treatment without resolving that problem. So we end up maybe consulting our MD, who is a GP, and say, please look at this blood pressure. Maybe they're not sleeping. Maybe they are truly hypertensive. So all this is from experience. As a leader, you must be able to listen, communicate, have an open mind, because sometimes it's not
it's not as easy as
it seems,
true. So over to you, Dr. Oge. Dr. Oge, I would like you to actually speak to what strategies do you think as the foundation for cancer care. I mean, you know that it focuses on cancer prevention, screening, and education. So what strategies do you think that non-profit organizations like the Foundation for Cancer Care and other non-profits, particularly in the cancer space, can implement or can adopt to further improve cancer prevention measures, and possibly make a recommendation also for government, those making policies, particularly in the cancer space?
Oh, that's a heavy one. And probably one answer would probably, cover, fit all. I think one of the challenges, so before you make recommendations, you have to identify what the challenges are. And one of the major challenges we've found at the Foundation for Cancer Care, which echoes across the non-for-profit, is the issue of funding.
And with the recent cuts that has gone on with funding globally now, I don't know how much what the future holds for cancer care generally.
Yes, and it's just a bit baffling to me when I turn on social media and there is so much money being, and I'm thinking, wow, this party would fund so many. That's the way I'm now thinking. I can't really go to social media and enjoy pictures without, the context.
Back to
exactly. So if there was a way funding could be made to look attractive to organizations. So I know organizations have CSR and all, but it's a bit of a hit and miss, when they feel like. And some organizations have specifics as well that they fund. So I think we've had this discussion at the foundation where we list certain organizations and target those who are health focused and oncology focused. So that's one strategy. Another strategy is that as much as we are directing a lot of attention to the public, I think more and more we also need to physically front face with those who provide funds. So I'm still on funds, to talk to them about the need for funding for, cancer. And so that strategy means that sometimes we have to leave our comfort zone. And sometimes our comfort zone is our patients. They are our patients, but we need the funds to be able to help the patient. So we need to step out boldly and sometimes put on that business corporate hat to go out and say, listen,
networking.
So that means attending a lot more conferences, identifying specific areas where that conversation is already taking place, and we are not on that table. We have to find ourselves on that table. So that's the strategy. The other strategy is, the honest truth is, we can't work without the government.
In fact, governance plays a major role in healthcare.
We can't work without the government. And I think what we've been doing in recent times is identifying conferences, things that the government's doing, and we have our representatives going, that networking, building connections, sort of talking, saying, hey, we are here, and this is what we are doing. And, you're planting the seed. So not all the seeds will germinate overnight. Some 10 years down the line, 20 years down the line.
And some actually may never germinate.
Exactly.
But at least the information is out there.
Because if the information is out, then there's something to wrong with should anything come up.
Exactly. And then I think the other thing as well in terms of strategy is you have to be well informed.
Absolutely.
You have to be well informed.
Because again, if you don't know when things are happening, then you can't push for it.
If you go into a space and they ask you a question and you cannot even speak about this. And so in line with the being well informed, at the foundation, one of the things we've been doing is all, down to from the coordinator to the officers training. I know we've done grant writing, and being topical about what's going on in the space so that you can speak knowledgeably about what you're doing. So that is very important, in this space that we're.
So do you think e-learning will help in this aspect?
Well, let me put it this way. The current module we have on the e-learning platform is targeted to the clinical, cancer screening and prevention. But you can actually upload another module that has to do with,
non-profit. Because again, there are technical parts of running a non-profit that, in fact, you don't even learn in schools. And some of these things are skills that you have to build up intentionally. Nobody intentionally says, oh, I'm going to school to learn about grant writing. But grant writing is a core part of your work in a non-profit. You're going to have to do monitoring of an evaluation of every project that you are doing. Because at the end of the day, your evaluation and your monitoring is what you can use to highlight your impact.
I'm wondering also because we had some doctors come in the other day, and a lot of them are asking questions. What about up north? What are we doing for up north where they do have the money, but they don't have the information that we need.
So I think that particular conversation, when it comes to things happening up north, actually there's work going on there. It's not as if there are no non-profits that are not doing things there. There are a lot of non-profits actually operating on the northern side of Nigeria. But what I would like to say is that maybe our coverage of care is not as universal as it should be. And that is a global problem.
And even inside the rural areas,
honestly,
we need...
The task is daunting. Let's put it that way.
Yes.
But Rome wasn't built in one day.
Yes.
And I think that question of strategies is a very important one, because those strategies, processes, systems, then would help the universal coverage of, you can then start identifying which areas. The other thing I wanted to say about the foundation strategy is your board.
Yes.
A foundation is only as good as its board.
Yes. I mean, let's talk about your impact on the foundation's board, actually, as the board advisor. We've done a lot of things that the foundation for cancer care.
It's fun.
It's fun.
We have a good team.
Yeah.
And the fact that those meetings are, they're regular.
Yeah.
They're serious,
and they address issues as they come.
Yes, and these are board members who have other lives.
Yes.
But when they come there, it sounds like this is the only job they are here to do.
Yeah.
And then we have the advisory areas, where we support the work, the coordinators and the officers. It doesn't mean it's perfect, and we're always fine-tuning to see how we can improve.
But again, I must say this, and I don't say this because I see you here. I think that we have an absolutely amazing board, both as board and as advisory at the Foundation for Cancer Care, and somehow it has been able to significantly drive the impact that we have made as a non-profit. And I'm going to give a classical example. So when it comes to running a non-profit, a lot of non-profits are dependent solely on funding. And while it might be easy to say, oh, we've gotten this fund, we've done this, now that funds are being cut off, what happens? Somehow the Foundation for Cancer Care is still able to get things done because we have a board that somehow they are committed to making things happen. I mean, Dr. Iwuji is a member of the board, and individually she raises funds to fund initiatives. If she's not running, she's individually committing an amount to radiotherapy treatment for cancer patients. And we have a number of board members like that when it's time for us to get things done, they literally will pull their weight. But at every point in time, the job gets done.
Everybody gets the job done.
Yes. And I think that is one thing that not every non-profit has. So for a non-profit, if you are listening to this, before you decide to go and start that non-profit, make sure that you have a formidable board that can drive impacts for you even when you are not present. And this would lead me to my final question to you, Dr. Oge. And I want you to speak basically looking overall to current state of healthcare now. How do you think we can improve patient-centered care and access to healthcare? And I'll give a classical example. Currently in Nigeria, there is only a single facility where you can access a PET scan in West Africa. So that means that if you are in Ghana and you want to do a PET scan, you have to come to Lagos. If you are in Gambia, if you're in Senegal, you have to come here. And to be honest, when it comes to cancer care, we always have this slogan that says early detection is key. But will there be detection without proper diagnosis? Will there be early detection when we don't have early diagnosis? So we have a limited resource to work with. So how do you think we can improve patient-centered care and access to cancer care?
That word, patient-centered care, right? It's a heavy one. Because it means that you're focusing on the patient, and everything else that comes with that patient. So even though you're talking about, access to care, as part of patient-centered care, we also have all the other things, the psychosocial, how robust is it? The financial support, financial navigation, the good crop of clinical personnel to deliver the care, the diagnostics and the laboratories. These are all patient-centered care, because it's not just when the patient is in front of you and you're talking to the patient. It's all the other things. You know, a patient can come to a facility and their complaint has nothing to do with the clinical care. But the patient-centered care, it might be that the front desk didn't do something right, or that they were leaving and the security person said something or did something. It might be that the security man did not allow their driver to drive in. Meanwhile, they are too weak to go from the front. There are all sorts of tentacles that come with patient-centered care and access to care. And it's simple. I don't have a huge narrative around it, but when I listen to other people talk, when I experience it personally, I just think that the public sector and the private sector need to work together. The government has to be at the root of it. If we take the United Kingdom, the UK, their healthcare was hinged on the NHS. Do you understand? And even though you are adding to the NHS, when you're taxed and all that, the government is running it. And then policies to guide, you know, to guide all the ideas that are coming.
So to our systems, we must have policies to guide the ideas.
We have policies. Then you take the US, they have a different system of healthcare. They have the insurance and they have a bit of, you know, the Medicaid, the public part of it. But again, the government is somehow at the end of it. So where is our government when we talk about Nigeria, Africa? And with the recent things happening, you know, with the US and all that, and funding generally, the one thing that people are saying that is resonating is Africa for Africa.
Yes, Africa has to look after itself.
Africa for Africa. Yeah. How long do you want to be spoon-fed? How long do you want to sort of keep saying we have bad leadership, so it's not going to work? And increasingly, what's happening in the last year or two, even before the whole thing happened with funding, COVID taught us a lesson.
Yes.
There are conversations being had in regions in Africa. Now, there are conferences. Before, you know, you say a conference is in Nigeria. Now, because of virtual learning, virtual meetings, I can join a meeting that is happening in Nairobi. Vice versa, even with the e-learning you mentioned, we have people from Tanzania and Uganda coming in. And I think the government is beginning to recognize that they are so far, but that conversation. So we belong to an association called the HFN, Healthcare Federation of Nigeria. It's sort of similar to the NCS and NICRAT and all, but they are broader because it's not just oncology. It's not just doctors. They have everyone, anyone, nurses and all that. And HFN's mandate is that they will speak to government, the healthcare team. They are the voice.
Yes.
And I think we need such engagement. I also think we need to step out of all our comfort zone. I think we need to do away with petty rivalry. And one day you will be a patient. One day your family member will be a patient. So what are we even
talking about?
What are we competing about? You know, and I see the wonderful collaboration the foundation does with other NGOs in the space. You don't have something, you call someone else. You are doing webinars. You contact someone. You know, it could be Abigail from, you know, it could be some other person to come and speak, and vice versa. When the other NGOs are doing stuff, they send us messages to say, please, can you be a member or a participant here, or we're giving you invitation to come in. So communication, like Cynthia is talking about, is key
in driving the impact of access to care.
So and to add to that, it's effective communication.
Effective communication as well.
So I just want to highlight that again. Sorry, I kind of read a lot. So I see that there's been much more recent advancement, particularly to cancer care in countries like Egypt, Kenya. You will meet them at the forefront of oncology care in recent times. And I'm just curious to know do you think there might be a chance that Nigeria might be getting closer to that side of things?
You know what? I think with the conversations being held at all these regions now, you know, conferences in Ghana and everybody comes there, you know, we just had a recent visit by a group from Egypt. The more you are exposed, the more you begin to see your lack and your gap. And as we begin to see the impact of good leadership, hopefully we will have leaders who decide to tap into what others are doing. and do it humbly as well. Wow. You know, that whole time where we just felt, you know, yeah, it doesn't matter. It matters.
It matters.
And COVID again taught us that you cannot, because you're rich and you're in quote a leader, escape abroad. Now companies are even withdrawing that whole, we have oil money, so we're sending our leaders, the executive. No, it's now, you know what, let's look. Oh, Lakeshore Cancer Center. Oh, this center. Oh, that. Yes. Please, we're sending our patients to you.
So basically, Africa has to intentionally look after itself. I'm very happy that we've had this conversation today. And it's very nice to have you, Dr. Oge, and Nurse Cynthia share your insights on women's leadership and its impact in cancer prevention and cancer care. We hope to see you again probably another time. But we are glad to have you. Thank you for having time with us.
Thank you for having us. And we also, just to add to that, we recommend screening. Screening is very, very important. We have clinical breast exam here every Wednesday, and it's free of charge.
Absolutely.
So you can come in and have it done clinically. And then when you go home, you continue doing it self breast examination. So I recommend that you take care of you. Thank you so much.
And my own last word is to dovetail back to the theme of this conversation, which is mentoring women's. And I would say I wish I had a mentor when I was sort of climbing, you know, I'm still climbing up. But I think that mentoring is so key. And I love the work that is being done in certain areas. So I belong to a group called Whisker, Women in Successful Careers. So I've mentored for them for 4 years.
Oh, wow.
And I learned from the mentees as well. And so I think for women's leadership as well, in addition to the training Cynthia mentioned, in addition to attending events, conferences, learning, I think it is a good idea to identify some role models, some mentors that you can bounce ideas.
Very important.
Yes. To know how does leadership, what does leadership look like? And how do I attain leadership as well?
All right. Thank you very much, Dr. Oge. Thank you, everyone. Again, for my final words, I would just like to emphasize that as young women looking to have a space or a room in healthcare, it's important that we know that there's a room for you, but in getting to that room, you have to intentionally make effort. You have to grow yourself. Like Nurse Cynthia had said, you cannot underestimate the power of training. So even as you're training, you are training on the job, about the job, but you are also training yourself for the other things that leadership will bring to your table. And it's important that we remember this. And while doing this as women, because women tend to do a lot of things, we are multitaskers and we forget ourselves. So while you are trying to grow in the place of leadership, do not underestimate your ability to also forget yourself. So you must intentionally plan to look after yourself. And that's where I would say, and on this note, I would say, do not forget that early detection is key to cancer prevention. So for every time, every month, make sure that you are checking yourself and doing your screenings annually. Bye.
Bye, everyone. Thank you.